Hey Mindy, if you're the host, can you enable screen sharing? I'll wait a couple minutes. Looks like people are slow to turn up, so. All right, well, it's 6:32. I'm gonna go ahead and get started. It's a good turnout. So I'm gonna be talking about cerebral palsy in the upper extremity today. This is just a brief outline of what I'm gonna cover in this talk. So cerebral palsy is a central nervous system insult. It occurs in the perinatal period, and it causes an upper motor neuron injury. And it's a non-progressive disturbance that occurs at some point in the developing fetal or infant brain. And it can occur anytime before birth, during birth, or within the first few years of life. And this insult affects the development of movement and posture, which causes varying degrees of activity limitations. And different patterns of body involvement can present. So patients may have diplegia, where the lower extremities are affected with little to no involvement of the upper extremities. In hemiplegia, one side of the body is affected, and the upper extremity is typically involved more than the lower extremity. And then quadriplegia is where all four limbs are involved. And this is the most severe type, and there's often involvement of the trunk and the face as well. And then they also often have pretty severe developmental disabilities as well. The most common manifestation of CP is motor spasticity, and this leads to muscle imbalances across the joint, and this over time causes joint deformity. And the peripheral manifestations depend on the extent and the specific area of the brain that are affected. So if we think back to medical school and our motor homunculus, you can see that there's a significant amount of the motor cortex that's dedicated to the upper extremity and the hand specifically. So if there's an insult to any area of the cortex within that range, then the upper extremity is going to be affected. There are kind of two groups of causes for CP. Congenital is the most common. It makes up 85 to 90% of cases. And sometimes the exact cause isn't known, but there are multiple different causes, as you can see there. And then acquired cases happen when the insult occurs after 28 days of life, but still within the first few years of life. And those are typically attributed to infections and head injury, but those are much less common than congenital causes. There are four types of cerebral palsy. Spastic is the most common, and that's what we're going to focus mostly on this morning. And these patients have increased muscle tone, which leads to muscle imbalances. Dyskinetic CP is difficult to treat, and these patients have a hard time controlling and coordinating their muscle movement. So they may have variable tone and speed of their movement. So they may have rapid and jerky movements at some times, and then this slow writhing movement patterns as well. And again, that's difficult to treat. And then ataxic, these patients have difficulty with balance and coordination. And then mixed is any combination of the other types, with spastic, dyskinetic being the most common. And the problems, or the primary problem of CP, is a problem of the brain, where they have issues with equilibrium and motor control, tone, and impaired sensation. But unfortunately, the primary problem of CP is generally not treatable. As I said, it's a non-progressive insult that can't be treated at the source. And so it's the secondary problems of CP that are the focus of most of our available treatments. So we have splints and bracing, therapy, medications, and surgery, which we're going to focus on, which are directed at treating the joint malpositioning, muscle imbalances, and then the resulting functional impairments. And we try to prevent these tertiary problems by intervening early, because the longer those muscle imbalances go on, they can lead to more severe skeletal deformity and contractures. So the most common deformity pattern seen in the upper extremity in CP is a pattern of shoulder internal rotation, elbow flexion, forearm pronation, wrist flexion, and ulnar deviation. They often have a thumb and palm deformity, and they may have clenched fist or swan neck deformity of the fingers. So they don't always have all of these deformities, but these are kind of the stereotypical presentation in the upper extremity. And treating these patients starts with a thorough evaluation, getting a good history. Again, these patients are often medically complicated, and it's important to note what other issues they have, if they have seizure disorder and other developmental disabilities, which indicate more global central nervous system involvement. And then you want to look at the motor system, starting with passive motion, which is really important because these patients often have contractures, but you need to distinguish whether that contracture is due to the joint itself or if it's just tight spastic muscles around the joint, because that's going to affect your treatment strategy. And so trying to assess their passive motion, you try to take them through slow, gentle, sustained resistance to try and overcome their muscle spasticity and assess their actual passive motion. And then you want to look at active motion as well, look at how the patient moves, try to have them perform different tasks and activities to look for, sorry, it looks like people maybe don't have the right link for conference. I don't know if it's a different link that Mindy sent out from what the normal one is, but.
I texted them, Lauren.
Okay, thank you. All right, so yeah, assessing their active motion and looking for dynamic deformity, because it's important to see what type of voluntary control they have of their motor system, because voluntary control is the best predictor for how these patients will do after surgery on the upper extremity, as far as what kind of functional improvement they'll get. And then you also want to look at their sensibility. Often these patients have some sort of sensory deficiency, but these deficiencies don't necessarily preclude them from having surgery. It's just important to factor into their evaluation. And one study actually did show that after surgery of the hand, some patients had improvement in their stereognosis. So they may actually get some improved sensibility after having surgery on the motor system. So getting into treatment, these patients require a multidisciplinary approach. They're often started in therapy fairly early on, depending on what kind of resources they have. But there's many people involved in the care. And so it's important to communicate with other providers as well and coming up with a treatment plan. And the options that we have at our disposal for treating CP specific in the upper extremity is occupational therapy, which plays a big role. We often try splinting and bracing initially. We try different medications. We have oral meds like baclofen and Valium, and then Botox injections have been successful in treating spasticity, and then ultimately surgery, which we'll spend most of our time on. And just a quick note about Botox. Treating spasticity with Botox injections is actually considered off-label use. It's not approved by the FDA, but it is used extensively. And the mechanism of action is it's good to keep in mind because this is a testable thing, but it provides a reversible block of acetylcholine release at the neuromuscular junction, which then prevents the stimulation of muscle contraction. So it helps a lot with spasticity. So the initial treatment, again, starts with bracing, stretching, and therapy, maybe trials of different pharmacologic interventions, but ultimately if patients fail those treatments or maybe they're not a candidate for some of them, surgery becomes an option. And in the upper extremity, we typically try to delay surgery until around the age of 7. It's felt that this is kind of the age when patients are cognitively able to cooperate, for one, with the preoperative evaluation to get an idea or a reliable exam on them, and then also to be able to participate in the post-op therapy protocols, which are critical to the success of surgery as well. And the goals of surgical treatment are to improve the joint positioning and maximize the hand function as an assist. It's not to try and normalize the use of the hand. And it's important for especially family members, parents to understand that, because again, that primary lesion that we talked about in the brain is not being treated and will always remain a limiting factor in their function. So we're just trying to optimize the use of the hand as an assist. And surgery is indicated in patients that have spasticity and contractures that have been unresponsive to non-operative treatment. If they have a specific functional impairment that can be improved by better joint positioning, that's a good, strong indication for surgery. And it's important to note that these patients with athetoid CP, that's a contraindication to most surgeries. Specifically, a lot of the soft tissue procedures that we have are not successful in those patients. And the treatment plan, or the surgical treatment plan, starts again with a thorough evaluation and then coming up with a problem list of the things that we're trying to treat. So looking at what muscles are spastic and may need to be released or lengthened, what muscles are flaccid or have poor motor control and may need to be augmented with tendon transfers, what muscles are under good voluntary control and available for those transfers. Is there athetosis or poor muscle coordination, as this can be a contraindication to some surgeries? And then are there joint contractures or joint instability, because this will need to be addressed as well. And we often try to perform multiple procedures in one setting if possible, rather than spacing the procedures out. It's just felt that that's easier on the patient as far as recovery and therapy and things like that. So there are three main categories of surgical options. There are soft tissue releases, tendon transfers, and bone and joint stabilization procedures. And if we revisit those common deformities that are seen in the upper extremity with CP, we'll kind of go through each of these and talk about the different surgical options for each. So starting with the elbow flexion deformity, this is primarily managed with soft tissue releases. The biceps and brachialis are often tight, and those can be released or lengthened. Capsular release of the joint is an option, but the longer this contracture has gone on, the neurovascular bundle is going to be contracted as well and can limit how much release you can actually get by a capsular release. So these pictures are demonstrating those lengthening procedures. So in the middle there, you can see the distal biceps tendon, and they've outlined their step cut for a lengthening. And then on the right there, you can see that's the brachialis deep in the wound there, and they've done a fractional lengthening to increase elbow extension. For pronation deformity, there's releases and transfers are both good options. Bone stabilization, such as rotational osteotomy, is not that common in CP. It's more often done for like brachial plexus patients. But you can release the pronator teres or the pronator quadratus. And then for transfers, you can reroute the pronator teres or the brachioradialis, or you can do an FCU to ECRB transfer. And so this is just demonstrating for pronation deformity, doing a pronator release, a pretty straightforward procedure where you simply release the insertion off of the mid radius. And this is a good option for patients who have a very spastic pronator teres. And so you just allow that to retract and then cast the patient in supination. Again, you can also do a pronator quadratus release, which is similar, just releasing its insertion off the radius. A pronator rerouting is often done as well, where the pronator is released and then passed around the other side of the radius to change its vector and convert it into a supinator. And then the FCU to ECRB tendon transfer, or the green transfer, is also an option. This is primarily done for wrist extension, but as the FCU is brought around the ulna, it also provides secondary supination. And so that is a good option to kind of treat two problems at once with one procedure. And lab studies have actually shown that this transfer provides the most biomechanically effective transfer for supination compared to the pronator rerouting or the brachioradialis rerouting. For wrist flexion deformity, if this deformity is severe, Patients can have problems with personal care or hygiene, function, obviously, and appearance are all negatively affected. For patients who are younger, and the contracture is not as severe and they still have some passive motion, tendon transfers are a good option. But the longer the contracture has been present, the more fixed it becomes. Joint stabilization, such as wrist fusion, is a better option. So for patients who may be skeletally mature, or patients that are very low functioning, a wrist fusion is a better option. So again, in patients that have passive motion but no active wrist extension, the tendon transfers are a good option. And all three that I listed on the previous slide have been shown to be effective for wrist extension, but the green transfer is the most commonly seen and the most commonly tested. So again, you're taking the FCU, transferring it to the ECRB or ECRL is an option as well. And that provides you with wrist extension and that secondary supination that we talked about as well. For patients, again, that are maybe skeletally mature or have fixed contractures or maybe very low functioning, wrist fusion is a good option. And as in any wrist fusion for other indications as well, the addition of a proximal row carpectomy is advantageous in that it decreases the amount of fusion surfaces, and it also provides a local bone graft. And then in CP, there's also the advantage of shortening the skeleton with the PRC, and that releases some of the tension and allows for better correction of the deformity. So moving down to finger deformities, there's kind of two main deformities. They may have finger flexion contractures, or some have swan neck deformity. And obviously those are treated differently. For finger flexion, you can do FDS or FDP lengthening or a flexor origin slide. And then for swan neck deformity, you can do intrinsic lengthening or central slip tenotomy based on the cause of the swan neck, which we'll talk a little bit more about. And then there are some tendon transfers available. Some prefer to do lateral band rerouting, and then joint stabilization procedures as well. So for finger flexion, the flexor pronator slide is a good option when they also have involvement of the tight wrist flexors as well as tight pronator, because when you release that origin off the medial side of the elbow, that releases the tension for all three of those structures, and then that allows the wrist and finger extensors to function better. But for swan neck deformity, as I mentioned, there's two different causes for swan neck in CP. It's either due to hand intrinsic spasticity or due to overpull of the extrinsic digital extensors. And it's important to differentiate between the two causes because that's going to determine how you treat it. And you can distinguish between the two in a couple of ways. Looking at the position of the MCP joints when the patient tries to actively extend the fingers will give you a clue. So in cases where the intrinsics are tight, the MCP joint will flex when the patient attempts to extend because the intrinsics are volar to the axis of rotation of the MCP joints. And then you can also do a Bonnell test for intrinsic tightness, which will be positive, obviously. So they will have improved passive flexion of the PIP joints when the MCP joints are flexed. And then in cases where it's due to overpull of the extrinsics, the patients will have, the MCP joints will be in extension when the patients actively extend their fingers. And these patients typically have a wrist flexion contracture as well. And so over time, their wrist extensors are kind of working overdrive, trying to pull their wrist into extension as well. And over time, that leads to the laxity of the volar plate at the PIP joint and the resulting swan neck. And then in these patients, the Bonnell test will be negative. So in cases of intrinsic tightness as a cause of the swan neck, you can do intrinsic lengthenings. This is typically done with an incision in the palm. You want to obviously find your common neurovascular bundles and retract those. You do a fractional lengthening of the lumbricals, and then also fractional lengthenings of the volar and dorsal interossei as well. And then if it's due to overpull of those extrinsics, you can do a central slip tenotomy to release the tightness on those structures as well. And that will correct the deformity in most cases. Some people prefer to do this lateral band rerouting procedure. So as we know in swan neck deformity, the lateral bands migrate dorsally. And so this procedure reroutes them to bring the lateral bands volar to the axis of rotation of the PIP joint, which then corrects that extension deformity. And then moving into the thumb and palm deformity, which is probably the most complex problem of the upper extremity in patients with CP. And it's caused by that imbalance across the thumb. So you have tight flexion and adduction muscles, and then weak extension and abduction muscles. And originally described by House, there are 4 types of thumb and palm deformity. So type 1, patients just have adduction of the first ray. In type 2, they also have flexion of the MCP joint. In type 3, chronic adduction of the first ray over time leads to laxity of the MCP joint volar plate and secondary hyperextension of the MCP joint. And then in type 4, they have adduction, MCP joint flexion, as well as IP joint flexion. And there's, the indications for surgery in patients with thumb and palm deformity are when they have a functional impairment due to the position of the thumb that prevents them from being able to grasp or pinch objects. And that's in patients that are more functional. And then it's also indicated in patients that may be non-functional, but the deformity is severe and can cause problems with hygiene. And so there's many different procedures have been described for this problem. I'll kind of go through the most common procedures, specifically for a type 1 thumb and palm, where you release the adductor pollicis in the palm and then do an EPL rerouting as well. So this technique described or shown here was originally described by Matev, where you make an incision kind of along the thenar crease in the palm and release the adductor off of the origin on the radial side of the third metacarpal. So that releases your adductor, and then if needed, you can also release the thenars and the FPB muscle through that incision as well. And then along with releasing those tight structures, you also often need to augment the weak extensors. So with the EPL in its normal position around Lister's tubercle, it functions as an adductor as well as as an extensor, as well as a secondary adductor of the thumb. And so taking it out of its compartment and rerouting it through the first compartment converts it into a thumb abductor, which can be helpful. So you can see there's an incision made at the base of the thumb, and the EPL is released over the MCP joint. It's delivered proximally through a wound at the wrist and then rerouted either through the first dorsal compartment, or I think subcutaneously is an option too, and then reconnected at the thumb, again, to provide that abduction moment. And then those are, as I said, those are kind of the most common procedures done. And then additional procedures can be done as well, depending on the type of deformity. So what is tight and what's weak. So in cases of type 2, where the MCP joint is flexed as well, like I said, you can release the FPB muscle or the thenar muscles. In type 3, where you have hyperextension of the MCP joint, as shown in the picture there, you can do an MCP joint capsulodesis, or you can fuse the joints. And then in type 4s, where the IP joint is flexed as well, you can also do an FPL lengthening. So obviously there's a lot to consider in treating these patients and trying to come up with the best surgical plan. The goal is balancing the joint and getting the joint into a more functional position, but this can be difficult to obtain in the first place and then to maintain it as well. Complications of these surgeries involve overcorrection of the deformity, undercorrection. Often they can have recurrence of the deformity, especially in young patients as their skeleton grows. And then they may still have a lack of improved function despite the joint being in a better position. So all complications that can occur with these procedures. But just to try to wrap things up, CP, as I mentioned, is a problem that starts in the brain, and that's the primary problem. But our treatment is aimed at those secondary and tertiary problems because we can't really go back and change the original insult that took place. So early treatment for CP patients involves a lot of therapy often. We try bracing, various medications, but then in cases where those are not successful, we have multiple surgical options based on what the deformity and what their limitations are. We typically try to delay surgery in these patients until they're of an appropriate age where they can participate in the therapy, which is really important for successful outcomes. As we talked about, you want to tailor the surgical plan to individual patients' deformity and then also what their goals are. And again, as I mentioned, voluntary control is the best predictor of functional improvement after upper extremity surgical treatment. So that's important, maybe a testable thing. And then our three main categories of surgical options, as we talked about: soft tissue releases, tendon transfers, and joint stabilization. And this chart is just kind of reviewing the most common procedures done for each of those different deformities that we see in the upper extremity. And that's all I got. Take any comments or questions.
That was outstanding, Lauren. A really difficult topic to cover. So CP is like tetraplegic hand surgery too. So you have to really think what's going to best benefit the patient, because you may do a procedure that has no benefit for them. And I think you recently saw a young CP or a CP girl that I had, she's in her 20s or so. She had a thumb and palm deformity. That was very difficult. I had done 2 procedures before and they didn't work. They were tendon transfers. And this time I had to do a fusion just to get her thumb out of her palm. That's going to be very debilitating for high functioning patients with CP.
Yeah.
The one other thing is you want to make sure you don't have a, if you end up, if you take away their tenodesis effect with a wrist fusion, sorry, y'all, I'm in the elevator. If you take away their tenodesis effect with a wrist fusion and they rely on that, it can be very detrimental to their function. So you have to make sure that, you know, they don't use tenodesis for some of their function.
Sure. Does anybody have any cases to show?
Dr. Freilich wanted me to present one. Are you in the meeting, Dr. Freilich? Maybe not.
Does not look like it.
All right, I guess I'll wait till next week then.
Just present it anyways.
Okay. Hey, Mindy, could you enable share screening again?
I wonder, I think she made me the host, so
Okay.
I wonder if I can do that. Does anyone know how to do that? Let's see. I don't know how to enable screen sharing. Does anyone have any tips? More. I looked there. I didn't.
Lauren, at the bottom of your screen, it should say, there's like a little arrow to the right of where the green share screen is, and then you click on that and it should say like enable screen sharing.
Oh, multiple, let's see. Glenn, try it now.
Do it now.
Okay, great.
Thanks, Dr. Behar.
Anytime.
Are you guys seeing the PowerPoint?
Yeah.
Yes.
All right, cool. All right, so this is a 35-year-old male. He sustained some injuries falling 16 feet off a ladder back in March. It's a work comp case. He was seen at an outside hospital. He had an open wrist fracture and a elbow dislocation, and he underwent IND and fixation of his distal radius and ulna. The wrist was also X-fixed, and then his radial head was replaced, and the elbow was X-fixed as well. And then due to some not completely known circumstances, he ended up presenting to our ED to get follow-up with us, and then we saw him in clinic. We saw him about 6 weeks after all those surgeries. He still had his X-fixes in place, a large lateral elbow eschar, and he had a high radial nerve palsy. It seemed like one of the X-fix pins were probably had injured his radial nerve, and we ended up removing the X-fixes, and his elbow range of motion is about 45 to 110, and the rest of his nerve exam was normal. So these are his X-rays when he presented with the X-fixes still on. You can see that the distal radius and ulna were fixed with plates. The ulna seems to be a little bit positive in variance. And then here, we took off the X-fix, and these are his form films. You can see that the radial head is dislocated. These are dedicated elbow films. And then there's a lot of heterotopic bone forming anteriorly in his elbow as well.
Hey, Glenn, did they have a good neurovascular exam when he came in? Like, are you pretty sure it was the pins and wasn't like, I mean, that elbow injury could have definitely caused a PIN injury or something as well. You're pretty sure it was the X-fix?
Because it's a higher radial nerve injury, he doesn't have sensation in dorsum of his hand either. And I think on subsequent exams, he couldn't extend his wrist either.
Okay.
But yeah, that is a good consideration. And that's X-rays of his wrist with the X-fix off. The ulnar head seems to be dorsally dislocated as well, perhaps. On one other repeat exam, there was a positive Tinel at one of the lateral pin sites. There was no improvement in his palsy. An EMG was obtained recently. It showed high radial nerve neuropathy with ongoing denervation. And then a CT scan was obtained just to look at the heterotopic bone in his elbow. And these are kind of selected cuts, and most of it's near the coronoid. So he wanted to get everyone's thoughts about what we want to try with this guy. I think in terms of his radial head, it could be due to not getting the proper length with fixation at the wrist, if he has some sort of excess Lepresti injury as well. And then trying to kind of reduce the radial head at this point seems like it would be quite difficult. He dislocated even with the X-Fix on. And then in terms of the radial nerve, or the radial nerve, we probably need to consider tendon transfers, possibly, or exploring the nerve at the pin site and then repairing it, and probably doing tendon transfers on the line. We'll see. But yeah, he wanted to see if anyone else had any thoughts regarding this patient.
So why do you think it dislocated in the X-Fix? The elbow. Other than lack of loss to follow up.
Could be I don't know, the medial stabilizers are out, or not fixing it correctly distally and then having some sort of interosseous membrane injury are my thoughts.
What I found with the elbow is if it's dislocating even after you fix the lateral sides, because the medial side's out too. And sometimes the X-Fix, especially, Chopper likes to really flex them up. But then, they had the coronoid injury as well. It probably was just both sides were disrupted, and then just couldn't hold it probably. The longitudinal injury of the forearm shouldn't necessarily affect the ulna. If you have if you have the ulnar fixation and the humeral fixation, it shouldn't affect the elbow reduction, right? So that part, shouldn't really be affected too much. This is a terrible injury.
Yeah, it's bad.
What's his so his radial nerve is out. What's his major defect? Has no forearm rotation, elbow stiff, can't move his wrist. What's the number one thing that he would do for him? Yeah.
Well, firstly, I never saw this guy, so I don't have a complete sense of what he wants to address first. And there's also a language barrier that made things a little bit difficult as well. But I think probably getting the radial head reduced would be my number one priority.
The ones like this I've had in the past, I've basically had to go in and reconstruct both sides. I took the radial head out, reconstruct medial and laterally, and then you place something back in to give you some sort of strut on the lateral side. A lot of times there's stuff in the joint. You really got to clean it out. It's never a very satisfying deal. You can get it reduced, but the motion's going to be terrible. And it probably have arthritic change already. So you're kind of just buying time, I think.
Do you think the distal side needs to get revised?
The ulna looks fine. I think you don't really have good forearm rotation, right? So you, it's hard to really assess what's going on distally at the DRUJ because you can't rotate proximally. So you're kind of pushing everything through that DRUJ to rotate. So the radius isn't really rolling over. It's just kind of bending over, so to speak. So I don't think you have a really good idea of what your DRUJ is like because you have nothing working proximally. So I'd probably start at the elbow and then work your way down if you need to.
And then probably, if you're going to consider tendon transfers for wrist extension or something like that, I mean, you may have to do something with the wrist, right? To be, if he has like a block to motion or something based on the reduction of the radius and something like that, I would think.
You think the radius is healed? I mean, I guess you get did the CT show the radius was healed, or it was just CT of the elbow?
It was just a CT of the elbow.
Hmm. It's tough one. Well, you didn't create the injury. So at least you got that going for you. You didn't create the injury.
Do you anticipate this heterotopic bone needs to be addressed in that setting?
Yeah, when you redo the elbow, you're gonna have to take all that stuff out. You're basically gonna make it a little bit more unstable to get the reduction you want. And then I would use allografts basically on both sides, get that thing reduced where you want it. Probably, I guess you'd be pretty gun shy about an X-fix again. But probably you'd have to do something like that just to make sure it stays. And then, just realize he's not going to have very good motion at all. You're just basically buying him a reduced joint so that you can hopefully have a better idea what's going on with the wrist. I mean, if you take the radial head out completely, your rotation will get better, but then you don't know what's going to happen with the interosseous membrane stuff. But that type of damage to the forearm, even at this point in time, you can't count on that being intact. So the longitudinal injury is pretty substantial for sure. Surprised they didn't bridge plate that.
Yeah, that was surprising that they chose to go the next fix. Anyone else have any other idea?
That's all I got. That's what I would do. I'd go elbow first and then kind of go from there.
Okay. Thank you.
All right.
All right, I think we're good for this morning. Thanks, everybody.
Thanks, everyone.